Dr. Patel. And with all of that said, I'm going to go ahead and stop sharing my screen and turn things over to you.
Thanks so much, Dalton, for that very kind introduction. You're going to make me blush on screen. So for those of you that don't know me, my name is Anand Patel. I am part of the Acute Leukemia and Myeloid Malignancy Program at the University of Chicago, where I take care of adult patients with these diseases. I also work very closely with our fellowship program, and I'm the medical director for our inpatient leukemia service. So today, really my focus is going to be on MPNs that are in progression to what we call the accelerated or blast phase. So when an MPN starts behaving more like an acute leukemia. These are my disclosures. And because of the nature of this talk, I won't just be talking about what are the current standard therapies, but also ongoing clinical trials and the such. So with that in mind, I will disclose when I'm talking about any medications that are being discussed outside of their FDA label. So really, over the next 30 to 40 minutes, I want to start by laying a foundation for just what our pH negative or classical myeloproliferative neoplasms are. We're going to focus on some of the risk scores that we can use, particularly in myelofibrosis, to identify patients that may be at increased risk of disease progression to the accelerated phase or blast phase, and really hone in on what those risk factors for progression are. And then when we move to the second half of the talk, really that's when we'll get into what treatments are available for accelerated and blast phase disease, along with novel therapeutic approaches that are under investigation. I find it always helpful to frame discussion around a patient or a few patients that may somewhat inform how I think about a patient's journey if and when they have a diagnosis like this. So there's a case presentation that I'll intermittently refer back to over the course of this talk. And this is really a patient that's representative of many patients I have taken care of with accelerated and blast phase MPNs. So this is a 60-year-old patient with polycythemia vera that was diagnosed 15 years ago and comes in with worsening symptoms, specifically night sweats, weight loss, and some abdominal fullness. The patient has noticed that their need for phlebotomy has been somewhat decreasing over the past year. The patient is also on hydroxyurea due to prior thrombosis. On exam, the patient has a very large spleen, 15 centimeters below the costophrenic angle. And when blood work is drawn, the patient has a very mild anemia and the white blood cell count is elevated with a normal platelet count. The peripheral smear shows some teardrop cells, but there are no blast cells or immature cells seen. And a bone marrow biopsy confirms that the patient's polycythemia vera has progressed to myelofibrosis, otherwise known as secondary myelofibrosis or post-PV myelofibrosis. Cytogenetic testing looks at the chromosomes of this patient's MPN, and they are normal. And there is molecular testing done as well that shows a JAK2 mutation, which has been present since the patient's PV diagnosis, along with the acquisition of three other mutations, ASXL1, SRSF2, and TP53, which we tend to refer to as higher risk mutations. So with that kind of grounding, I'm going to briefly cover the three most common chronic phase MPNs and how we kind of manage and typify those. So we have polycythemia vera, where the main thing you see on lab work is an elevated red blood cell count and hemoglobin along with hematocrit, what we refer to as erythrocytosis. And when you look at a bone marrow biopsy, what you see is basically increased numbers of all three types of cells: myeloid or white blood cells, erythroid or hemoglobin precursors, and then your megakaryocytes or platelet precursors. Virtually all patients have a mutation in a gene called JAK2 in those that have polycythemia vera. And polycythemia vera is associated with increased risk of clotting complications or thrombosis, and also an increased risk of progression to myelofibrosis or acute myeloid leukemia, otherwise known as blast phase MPN, when compared to E-tier essential thrombocythemia. So in transitioning to ET, for those patients, the primary thing we notice on blood work initially is an elevated platelet count, which are the clotting blood cells. In general, a bone marrow biopsy seems to be fairly normal looking, with the exception of increased megakaryocytes or platelet precursors. The driver genes that we see in ET are slightly more variable than what we see in PV. So about 60% of patients have a JAK2 mutation. Another 30% of patients will have a CALR or a MPL mutation. And then about 10% of patients have what we call triple negative disease, meaning none of these three mutations are found, although there may be other mutations that are noted. For these patients, there is an increased thrombotic or clotting risk if you specifically have a JAK2 mutation. And then if your platelet count becomes very high, there can actually be an increased risk of bleeding complications as well through something called acquired von Willebrand disease. And then last but not least, we have primary myelofibrosis or PMF. Here, the blood counts can be quite variable. So if you catch a patient very early in their myelofibrosis journey, the blood counts can actually be high, what we call prefibrotic PMF. In patients that have reached what we call the fibrotic stage of disease, blood counts may actually be low. You may have anemia, you may have low platelets. And when you do a bone marrow biopsy, you see fibrosis or scarring, and then you also see abnormal megakaryocytes. The molecular makeup of primary myelofibrosis is very similar to ET, in that about 60% of patients have a JAK2 mutation, about 30% have a CALR or MPL mutation, and then another 5 to 10% have triple negative disease. In general, primary myelofibrosis has the highest symptom burden associated with it and has a higher risk of evolution to an accelerated or blast phase. So myelofibrosis is probably the most heterogeneous of the three chronic phase MPNs. And when I say heterogeneous, I mean management of it can range all the way from keeping a close eye on things to JAK inhibitors to considering a stem cell transplant. So how do we arrive at which patients are at high risk and which patients are at low risk? And we have a whole kind of back pocket full of prognostic tools, which have evolved greatly over the last 20 years or so. So these have gone from purely clinical features, so things like blood counts, what the bone marrow looks like, to what I call the molecular era of MPNs, where we incorporate the presence or absence of high-risk mutations to really tailor our treatment recommendations for myelofibrosis. And the reason this matters is because these risk scores will oftentimes dictate what our recommendations are for a patient. So in patients with low-risk disease that don't have symptoms, we may just keep an eye on things with active surveillance and not need to start any medication. For patients with symptoms, we will typically use JAK inhibitors. And for patients with intermediate or high-risk disease, we strongly consider transplant evaluation. The other thing to make note of is patients can have an increased risk of progression to the accelerated or blast phase disease if they have intermediate or high-risk myelofibrosis. So one thing to note is JAK inhibitors are the kind of cornerstone of treatment of myelofibrosis, and they are incredibly effective for those with large spleens, high symptom burden, but there are some drawbacks to JAK inhibitors as well. They can lower your other blood counts, and sometimes that can be dose limiting. They have a modest, what we call anti-clonal effect. So they don't do a great job of completely getting rid of the MPN cells or the cancer cells. JAK inhibitors don't seem to impact the rate of progression to AML or blast phase. And when you follow patients on JAK inhibitors for a long period of time, such as what was done on one of the original Jakafi or ruxolitinib studies, COMFORT-1, about 3/4 of patients are off of the medication at 5 years, meaning there's only a subset of patients that benefit from these medications for many, many, many years. Let's go back to our patient. So as a reminder, this is a patient with polycythemia vera. Their disease has progressed to myelofibrosis, and we have now risk stratified this patient. They have intermediate 1 risk by the DIPSS+, which is an older risk score, and high risk by one of our molecular risk scores, the MIP70 version 2.0. Given the very large spleen, the patient is transitioned from hydroxyurea to ruxolitinib. Given the high-risk features of the patient's myelofibrosis, he is referred to be seen for an allogeneic stem cell transplant, and ultimately the patient elects to not pursue this at this time. And the patient feels much, much better with the initiation of ruxolitinib. The patient is on ruxolitinib for about 18 months, and unfortunately, symptoms return. This time around, the patient has worsening anemia, a hemoglobin of 8. Platelets are now low at 96,000. The white blood cell count is elevated, and when we look at the specific types of white blood cells, there are now 25% blasts or immature cells that are circulating in the blood. A bone marrow biopsy is done and confirms that the patient's myelofibrosis has progressed to acute myeloid leukemia or AML, otherwise known as MPN blast phase. On cytogenetics or chromosomal testing, the patient has acquired an abnormality in chromosome 7, what we call a monosomy 7, which means that one of the chromosomes has been deleted. And on molecular testing, many of the same mutations that were seen at the time of myelofibrosis are noted, and there's acquisition of an IDH2 mutation and one more TP53 mutation. So, when I talk about accelerated and blast phase MPNs, what do I mean? What that means is that your MPN has changed in the way it's behaving. Patients that are in the early phase or cellular phase, where the major issues we're dealing with are elevated blood counts, typically our goal is to reduce those blood counts, normalize them, reduce risk of blood clots, and also reduce risk of progression if we're able to. In patients who progress to the fibrotic phase of disease, where you're now dealing with low blood counts and a very scarred bone marrow, you're starting to think about things like JAK inhibitors. You're thinking about transplant if they're sufficiently high risk. And then if patients have 10% to 19% blasts, either in the blood or bone marrow, we refer to that as accelerated phase. And if patients have 20% or more blasts in the blood or the bone marrow, we refer to that as blast phase. You may hear the term post-MPN AML, meaning AML arising from an MPN. That term is synonymous with MPN blast phase. They mean the same thing. And really, the consideration here is to treat the disease as if it is AML, and then strongly consider trial participation and transplantation, given our current therapies have to do a lot more than they are to control this disease. What are the risk factors for transforming? So let's talk about the type of underlying MPN first. So patients with ET have the lowest risk of progressing to blast phase MPN. So if you follow a cohort of patients for 20 years, the risk of progression to blast phase in someone who has ET is about 4%, 7% in patients with PV, and about 14% in patients with primary myelofibrosis. Again, I want to emphasize this is follow-up for 20 years. So most patients will not have progression to accelerated or blast phase, but the risk is higher in those with primary myelofibrosis. The features that we otherwise identify besides myelofibrosis are ones like prior treatment with cytoreductive agents other than hydroxyurea. These are drugs we don't really use a whole lot anymore, phosphorus, chlorambucil, busulfan. So this was seen much more frequently in previous kind of management strategies many, many years ago, where these drugs were used more. When looking at blood work, if you start having blasts that are circulating in the blood, that is a predictor for progression to accelerated or blast phase. If you have worsening anemia or low platelets, and then a very high white blood cell count. And then when thinking about our prognostic scoring systems, so when you apply the standard myelofibrosis scoring systems, not only are very high risk categories at risk of disease progression and worse survival, but high risk categories are at risk for progression to the accelerated or blast phase of MPN. So why does acceleration happen? Why do we have progression from accelerated to blast phase? In my mind, the best way to think of it is in someone's bone marrow, if they have an MPN, that bone marrow has mutations that are present that lead to the MPN. There's also inflammation of that bone marrow, and that inflammation is ripe for allowing other mutations to develop. So if and when an MPN cell develops extra mutations, that can then put someone at risk of developing accelerated or blast phase disease. So the more complex your MPN cells become, the higher the risk of the disease becoming an accelerated or blast phase MPN. The other thing I want to highlight is that the route of progression is not the same for everyone. Some patients may lose their original mutation. So for example, if someone had a JAK2 mutation, it may go away if their disease progresses to an accelerated or blast phase disease. Other patients may have what we call multi-hits, so several mutations that are acquired in the specific MPN cells, that have the original mutation in JAK2, CALR, or MPL. And then you can also have a single hit, so one high-risk mutation such as TP53 that develops. I think this is important because if the route of progression to accelerated blast phase looked the same for everyone, we could think about using strategies that are kind of one size fits all. They are able to treat all patients that this happens for because the route of progression is the same. But because there's variety in how progression happens, we need to think about variable treatment options that are best fitted to the patient in front of us. This also shows that what mutations you develop and when have different impact on if and when your MPN will turn into an accelerated blast phase disease. So some mutations are associated with what we call late transformation, such as TP53, BCOR-L1, NRAS. So when you follow a group of patients that were published on in the study, it took about 20 years for their disease to go from a chronic MPN to an accelerated blast phase. But there are other mutations that are seen that lead to quicker transformation. DNMT3A, IDH mutations, EZH2, RUNX1, and U2AF1. I think this is important because this gives us a sense of what our window is to try and intervene with, say, something like a stem cell transplant if someone has a high-risk mutations but has not yet developed an accelerated or blast phase MPN. The other thing to highlight is historically, patients who have their disease turn into blast phase MPN do quite poorly. So this was a cohort of patients that was published on in 2018, so several years ago, really demonstrating that the improvement in blast phase MPNs has been very modest, even as we've jumped from pre-2000 to post-2000. Now, I'm going to pivot a little bit and talk about all of the different drugs we now have available to us for acute myeloid leukemia. The reason for this is most of our accelerated and blast phase MPN treatments are derived from what we have available in AML. So if it's a drug that's available to us in the space of AML, we typically are able to use it for accelerated and blast phase disease as well. So as you can see, there's really been what I call a therapeutic revolution in acute myeloid leukemia. There have been several therapies that have been approved since 2017, some of which are mutation specific. So for example, the IDH inhibitors, enasidenib, ivosidenib, olutasidenib. There are also what we call mutation agnostic approaches, meaning you can use this drug even if there's not a specific mutation present. Something like venetoclax, which is an oral anti-apoptosis drug, and oral decitabine cedazuridine. So drugs like that can be used no matter what mutational profile someone's AML has. While we use AML drugs, I think it is important to note that accelerated and blast phase MPN is not the same as someone who develops a brand new diagnosis of AML. And what I mean by that is the mutations that causes each of these diseases to develop are quite different. Some examples I will use is patients who have a de novo AML, meaning AML that develops without a prior MPN or other blood cancer. They tend to have higher rates of a mutation called FLT3, one called NPM1. On the other hand, patients with accelerated or blast phase MPNs, you see enrichment for mutations in IDH1 and 2, RUNX1, ASXL1, and TP53. And this is represented in a slightly different way with this dot plot on the right. So if you would think about a diagonal line that cuts exactly through the middle, the dots that are closest to that line are seen in equivalent percentages of kind of de novo AML and blast phase. And then the dots that are to the far right tend to be much more enriched in blast phase MPNs versus AML. So again, IDH mutations, RUNX1, SRSF2, TP53. And this is important because how we treat accelerated and blast phase MPNs should really take into consideration what mutations are present. So how are we doing when treating accelerated and blast phase disease in the current era of AML treatment? So with all these new drugs, how much better are we doing, if at all? I'd say we still have a lot of work to do. So when we looked at a 200 patient cohort across various academic centers in the North America. What we found was that the median overall survival was about 10 months for patients if and when they develop accelerated blast phase disease. I think one other important thing to note is more intense does not reflect better outcomes. So we looked at the most common treatment approaches used. So DNA methyltransferase inhibitor-based therapy, DNA methyltransferase inhibitors plus the drug venetoclax, and then standard high-dose intensive chemotherapy. And as you can see, if you look at these survival curves, they largely sit on top of each other, meaning more intense is not necessarily better. And in many ways, less intense therapy may allow for equivalent survival and potentially better survival because you're not dealing with as much in the way of toxic side effects. The other important thing to note is of the 200 odd patients that we looked at, only 14% of patients were treated on a clinical trial. I think this highlights the fact that we need to do better at developing more novel clinical trial therapies for patients with accelerated and blast phase MPNs. The other thing I'll note is we tend to use risk stratification tools that are developed for patients with AML and try to apply them to those with accelerated and blast phase disease. And while they are somewhat helpful, favorable risk patients by these scores tend to do better than those with high risk disease. These scores leave a lot to be desired as well. So something we use to measure the accuracy of risk scores is what's called a C index. So a C index of 1 is perfect. A C index of 0.5 is essentially a coin flip. And you can see almost all of these different AML tools that we use, when we apply them to patients with accelerated and blast phase disease, they perform about as well as a coin flip or maybe a little better than a coin flip. Some mutations of note that tell us whether patients are going to do better versus worse. IDH2 mutations are associated with better outcomes. And then the mutations in the red box below are associated with worse outcomes. So ideally, when we develop novel risk scores for patients with accelerated blast phase MPNs, specifically for those patients, we should be considering the presence or absence of these mutations, some of which are not actually represented in AML-specific risk scores. One thing to note is patients that make it to transplant, particularly in the accelerated phase of disease, do quite well. So this was an analysis that looked at 35 patients with accelerated phase myelofibrosis. As a reminder, accelerated phase means 10 to 19% blasts, and their 3-year overall survival was just under 70%. And that was very similar to what was seen in a cohort of patients with chronic phase myelofibrosis. So for patients who are candidates and well enough to receive allogeneic transplant in the accelerated phase, that should strongly be considered. When patients do get to blast phase, however, while transplant does help, the benefit of it is somewhat muted. We typically do need patients to be in remission, meaning less than 5% blasts, to benefit the most from an allogeneic transplant. So how do we do better for our patients with accelerated and blast phase disease? In my mind, it comes down to 3 specific things. The first is identifying patients with the highest risk of progression, because the optimal time to intervene is before accelerated or blast phase ever happens. The second is thinking about earlier intervention and treatment in high-risk patients. So whether it's early stem cell transplant, whether we develop drugs that help to delay or prevent the progression to accelerated or blast phase disease, that's really where our opportunity is to intervene. And then the last thing I want to highlight is how do we better incorporate targeted therapy into accelerated and blast phase disease? So drugs that target the specific mutations that are seen in accelerated and blast phase MPNs. So one, I think, proof of principle is IDH mutations. So IDH1 and IDH2 mutations are involved in the metabolic processes of cancer cells, and IDH1 and IDH2 mutations are seen in about 25% of patients with accelerated and blast phase disease. We also have 3 approved drugs in the AML space that we can borrow from, ivosidenib and olutasidenib, which target IDH1, and enasidenib, which targets IDH2. So at the University of Chicago, we looked to see how effective are IDH inhibitors for patients with accelerated or blast phase disease that have an IDH mutation. And what we found was quite encouraging. So, small numbers, this was only 8 patients, but in our 8 patients that were treated with IDH inhibitors, 4 of them were on treatment for a year or longer, and the longest responding patient was on an IDH inhibitor for over 4 years with their disease well controlled. So, quite a stark difference compared to what we've historically seen in our patients with accelerated and blast phase disease. One thing to note, however, is while IDH inhibitors treat the leukemic component of disease, they get rid of the blasts, IDH inhibitors don't tend to do a whole lot about the underlying chronic phase MPN. And these are some microscopic pictures that represent that. So the top shows treatment of the before treatment of the blast phase. The bottom shows the blast phase disease going away, but all of the features of the underlying MPN still being present. The benefit of IDH inhibitors has been seen in other patient cohorts as well. So similar findings that were reported by our colleagues at MD Anderson, and also in a multi-center approach led by the Mayo Group, along with us looking at the use of these drugs in a multi-center patient approach as well. One thing to highlight is we don't yet know when the best time is to use IDH inhibitors for patients with IDH mutations, whether they should be used right away or used down the road if patients don't respond to an initial therapy. But I think it's very clear that IDH1 and IDH2 mutated patients with accelerated and blast phase disease tend to do better because we have more options available for them. Another thing to kind of note and think about is how could we potentially address both the blast phase of disease and the underlying MPN? And the rationale for using a JAK2 inhibitor, something like ruxolitinib, along with IDH inhibitors, has been demonstrated in preclinical work looking at mouse models, and that is then translated into work that's looked at this prospectively. So this is a small clinical trial, 6 patients, that looked at the use of the IDH2 inhibitor enasidenib along with the JAK inhibitor ruxolitinib in patients with an IDH2 mutation, demonstrating durable benefit. And we at the University of Chicago have a trial for those with an IDH1 mutation looking at ivosidenib, an IDH1 inhibitor, plus ruxolitinib to really see if we can use these 2 drugs safely and effectively to benefit our patients with IDH1 mutations and advanced MPN. So, what approaches hold promise in the future? Thankfully, there are several studies that have been reported out on that look at novel treatment approaches that have sound rationale and will be explored in the near future in the context of clinical trials. This is a really nice graphic that kind of shows all the different places we can intervene. So we've talked about our IDH mutations. There are proteins that help cells stay alive when they shouldn't, called anti-apoptotic proteins like BCL2, BCLXL. And then a pathway I'm particularly interested in is something called LSD1. And we're going to talk about that here now. So LSD1 is basically a regulator of stem cells, and inhibiting or stopping LSD1 is helpful in treating disease in patients with MPNs. So this has been seen in mouse models, and there have also been studies done looking at the LSD1 inhibitor bomedemstat in patients with myelofibrosis and essential thrombocythemia. And there's an ongoing phase 3 study in essential thrombocythemia to see if bomedemstat is better than our current standard of care for patients with ET. Now, where we are looking to kind of push LSD1 inhibition is into accelerated and blast phase disease. So there's another LSD1 inhibitor called iadademstat that's been studied in AML and demonstrated high remission rates. Additionally, the responses seem to be preserved even in the mutations that are most common in those with accelerated and blast phase MPNs. So really giving us some insight that perhaps this is a drug that will offer some benefit for accelerated and blast phase disease. And that has then led to the development and an opening of a clinical trial looking at an oral decitabine compound called ASTX727 with or without the LSD1 inhibitor iadademstat. So this is a study that's open across the country. There are several sites that are participating, and we think hopefully this will provide a clinical trial option for many of our patients if and when they are diagnosed with accelerated or blast phase MPNs. Another intriguing target is one called BCL-XL. So there's an early phase study looking at a BCL-XL inhibitor called navitoclax combined with decitabine and venetoclax that has shown some benefit. And there are several other BCL-XL directed drugs that are in development and hopefully will be specifically looked at in patients with accelerated and blast phase MPNs. And other targets of interest, as I mentioned, it's a very exciting time. There are several other drugs and compounds that have very sound rationale for investigating them. And my hope is investigators like myself, my colleagues in the field, are really looking to figure out how can we then investigate these different drugs and offer a new paradigm for treating patients with accelerated and blast phase MPNs, where we don't just have to rely on the drugs that are available for AML, recognizing that really we need to develop therapies specifically for our patients with accelerated and blast phase MPNs. So how do we consider treating patients with accelerated and blast phase MPNs? A few things I will mention. Getting molecular testing is essential. We should absolutely know what someone's IDH1, IDH2 status is. Clinical trials would be the preferred treatment approach, given that the standard of care leaves a lot to be desired. And in patients in accelerated phase, you could think about going directly to a stem cell transplant without treatment of the accelerated phase. If and when the disease is controlled, a patient should be taken to transplant if they're an appropriate candidate, as that is really the only curative approach we have for accelerated and blast phase MPN. So let's turn back to our patient. So this was our patient with blast phase MPN that arose from underlying post-PV myelofibrosis. The patient had an IDH2 mutation, and this allowed him to be treated on a clinical trial that looked at enasidenib combined with a standard AML drug called azacitidine. This patient achieved a complete remission and has maintained that remission, continues to be on enasidenib, and we are now considering transplantation for this patient. So in summary, there are several risk factors that can help us identify patients that may be at higher risk of progressing to accelerated blast phase disease, including high-risk mutations. With our current standard therapies, we still need to do much better than we currently are for patients with accelerated and blast phase disease. And IDH inhibition offers an interesting proof of principle of using targeted therapies, seeing durable responses, and then thinking about what other targeted therapies we should be looking at in the space of accelerated and blast phase MPNs. So with that, I want to acknowledge several of the faculty members that I have the privilege of working with every day, along with the rest of our leukemia and myeloid malignancy clinical team. Most importantly, the many patients that I have the privilege of caring for, along with their friends, family support system, and then support that I have from the National Cancer Institute's Early Career Investigator Award. So with that, thank you so much for your time. Thank you so much for tuning in, and I am happy to take questions.
Awesome. That was wonderful, Dr. Patel. So incredibly informative. And we do have a couple of questions already in here. So we'll go ahead and hop in with those. Our first question is, what are some signs and symptoms that a patient should know about and report to their oncologist?
So that's a great question. Some things to look out for, I would say, is worsening of MPN symptoms that a patient may have that were previously controlled and then kind of popping back up or getting worse. So some examples would be drenching night sweats, fevers, chills, feeling like your spleen is getting bigger, worsening of bone pain if that's something that had gone away and has now come back. Those are some of the signs and symptoms that can be looked for kind of on a day-to-day basis. On lab work, the main things that we would be keeping an eye out for is worsening of blood counts. So say if you had a dropping platelet count, your hemoglobin was worsening. And then when we look at what's called a differential, when we look at the different types of white blood cells, if we are starting to see blast cells in the blood, that may be another clue that someone's disease is starting to behave more like an accelerated or blast phase.
Okay. And that actually leads into another question. Do blast percentages show up in a standard CBC or is a special test needed?
So that is a great question. So a typically what needs to be ordered to look at a blast percentage is what's called a CBC with differential. So a CBC or complete blood count will just report the specific values of white blood cells, red blood cells, hemoglobin, platelet, etc. The differential part, CBC with differential, means that someone then reviews the white blood cells and classifies what they look like. That is what is needed to identify if blast percentage is there or not. Oftentimes, if there are no blasts seen, they just aren't reported on the differential. So it's not like it'll say blast zero. They just won't be reported at all usually.
And our next question up is, how often should I have a bone marrow biopsy to check for acquisition of a secondary non-driver mutation? The individual asking is post-ET myelofibrosis.
Yeah, that's a great question. So, one thing I will say is that most molecular testing for MPNs these days can be sent from the blood and not just from the bone marrow. And the rate of concordance, meaning how closely would molecular testing from the blood and from the bone marrow track, it's over 90%. So sending molecular testing from the blood is very reasonable. That being said, in patients who have stable symptoms, stable blood counts, don't really have any new blasts in the blood popping up, etc., we probably don't gain a whole lot by checking molecular testing on a somewhat routine basis. It really should be driven by a change in symptom burden and or blood counts. And if there's any indication for repeating a bone marrow biopsy, it certainly would make sense to send off molecular testing from that bone marrow biopsy.
Okay. And then this next question is just kind of more broadly speaking about clinical trials. But is it a good idea to join a study to help ourselves, or are there any things that patients should be careful of when joining these study groups?
So I think I'm going to talk very broadly about clinical trials, and maybe that's the best way to kind of approach this question. So every clinical trial has a different objective or goal in mind. There are what we call registrational studies or registry studies. So that's really where they may not be a clinical trial that's looking at a new drug, but really what a hematologist or a research group is trying to answer is how do patients do over a period of time with a certain type of disease. Sometimes those will also ask for maybe additional blood samples to be collected. Maybe if a bone marrow biopsy is done, they may ask for an extra sample of that to be collected. And those studies, I would say, help us to get a better sense of where the gaps are for patients with blood cancers or MPNs. So it may not be a study that benefits you as a patient directly, but by volunteering and being willing to allow your information to be included in a study like that, it can really help us gain that knowledge across hundreds and hundreds of patients of where we need to do better. I'll now talk about clinical trials. So, clinical trials looking at new drugs, novel drugs, there are different phases to these studies. Phase one studies tend to be with newer drugs that don't have a lot of experience set in the clinical trial or disease space that's being looked at. Oftentimes, for a phase one study, the main thing that's being looked at is what dose of the drug is the right and appropriate dose to be used. And then they'll also be looking somewhat at efficacy, but really it's safety of the drug. And for studies like that, a patient could benefit from having access to a novel drug, particularly if it's not one that they can't otherwise use, and maybe all the other standard drugs that would be available for their disease have already been used. But there's no guarantee of benefit. So I think a patient really has to be in the frame of mind to say, this is a drug that could help me, but that is not the purpose of me going on the study. Really, the purpose of the study is to identify what the right doses of the drug is and whether it should move further into development. The next phase of clinical trials are phase two studies. So those are studies that will look at some sort of marker that associates with benefit or response. So a good example is, there may be phase two studies that look at spleen size and myelofibrosis. And then a phase three study is what we call a pivotal study, meaning it's usually a phase three study that's required for a drug to become a new standard of care treatment. So typically, phase three studies are randomized, meaning some patients enrolled receive the standard drug that's available, and then other patients receive the investigational drug or the drug that we think could be better than our current standard. Many times these studies can be blinded, so the physician, the patient, et cetera, don't know if they are receiving the investigational drug, but everyone on the study typically receives the standard drug. Many patients ask me, does a phase 3 study, could there be any chance that I'm receiving no treatment at all? If there's a appropriate standard treatment that's available, that's typically what's provided as what we call the control arm or the standard arm. So I think that's important to know. Um, and then, yeah, so I think for each individual study, I think it's important to ask your doctor, what are the goals of the study? And how do you think I personally would benefit? Or how do you think the MPN community would benefit? I find that when I speak with patients about studies, when I address those specific questions, that tends to give my patient the frame of reference they need to ultimately decide, is this study right for me or not?
That's a great answer. And I like how you covered that patients, if there's a standard therapy available, you're not going to receive no treatment. That patients are going to be receiving at least a standard line of therapy. I know that's a concern that some people have, so I appreciate you covering that one. And then our next question. This individual's had their blood counts bouncing around a little bit, and they just want to see how concerned they should be. Um, their white blood cells were staying around 20 for a while and then jumped up to 27 and then 25. When patients see numbers moving around like that, how big of a red flag should that be for them?
Yeah, so I would say, certainly we can see fluctuations in the white blood cell count for patients with MPNs. Like even something like a cold can cause someone's white blood cell count to jump up if they have an underlying MPN. I think this is where a I think this is where making sure that if a oncologist or hematologist or is ordering blood work and when they're getting CBCs, getting that differential where they're reporting out the specific white blood cells can be so important because that can give you a better sense of, is the white blood cell count elevated, but something we can keep a close eye on? Or are there some features here where we're maybe a bit more concerned and need to do some more investigation?
The next question up, I think would be good if you could just speak a little bit about how patients can ask to have a consultation with a stem cell transplant specialist. This individual is saying that they have pre-fibrotic myelofibrosis. If Jakafi helps normalize my blood work, am I still a candidate for a stem cell transplant?
Yeah, so I think the thing I'll say about stem cell transplant is it has its own risk associated with it. So with that in mind, someone's MPN has to be high risk enough for the team caring for them and the patient to feel comfortable taking on the risk associated with a stem cell transplant. And what I mean by that is in patients with lower risk myelofibrosis, when we use our different risk scores, in general, those patients tend to do just as well or maybe even better without a transplant than if they receive a transplant. On the other hand, those patients with higher risk myelofibrosis, they tend to benefit from a transplant because their disease is more likely to become aggressive and misbehave. So in someone with, say, normal blood counts, even with normal blood counts, if they have high risk myelofibrosis based on these risk scores, it may still be beneficial to at least meet with a stem cell expert to get the workup done for a stem cell transplant and see, are there donors out there? What could things look like if I were to need a transplant, even if it's not being immediately considered for them?
And then we've got just a few questions left here. Our next one, I'm gonna paraphrase it just a little bit, but this individual is ET. They have a CALR mutation with ET. They also have MBL that's looking like it's progressing to CLL. They're on hydroxyurea and a blood thinner, and their platelet counts are dropping. They just want to know what sorts of tests they should ask their oncologist to see if they could potentially be progressing towards accelerated phase or blast phase MPN.
Yeah, so again, I'm sounding a little bit like a broken record, but the CBC with differential, it's like a super easy test to order, but it's so incredibly useful. It's so incredibly informative. So if and when blood counts are being checked, I would advocate for a differential being done every time. at whatever cadence or frequency your hematologist or oncologist is following your blood work. Now, something that can be hard to tease out if and when a new treatment is started for someone with PV or ET is many of these drugs work by reducing your blood counts, and sometimes we overshoot. So sometimes when a new drug is started, there is this period where the dose of the drug has to be adjusted. So sometimes if the let's say platelet count drops lower than I would like it to, I may hold the hydroxyurea, I may have the dose of hydroxyurea, and then kind of see what the blood work does over the next 4 to 6 weeks. So sometimes that's the strategy that needs to be employed to get a sense of, is someone's platelet count truly dropping because of their MPN, or is the platelet count dropping because of the treatment we just started, and maybe we need to back off the dose a little bit?
And then finally, our last question that we have in right now is this individual says, "Thank you for all of the information. I am curious to know if the IADMSTAT study will eventually be enrolling at other cancer centers. I am not a candidate yet, but it sounds very promising."
Yeah, so this is a national study, so it is open at several sites beyond just the University of Chicago. There are sites, I'd say, as I can think of, yeah, we've got kind of representation on both coasts and the Midwest. Um, the slide deck I shared does have the clinicaltrials.gov number, so I believe Dalton will be sending out those slides.
Mhm.
But if you go to clinicaltrials.gov and type in the number for the study, they are always updating the specific sites that have the study open. So that would be a very good way to see where the nearest site would be if someone would need that study or would need to be thinking about that study.
Okay. And I just had one last question roll in. But for polycythemia vera, is the most important lab hematocrit, having that number below 45, or are there other lab numbers that patients should really be paying attention to?
Yeah, I would say that the main lab value that we want to keep controlled is the hematocrit. Absolutely. Sometimes, things like a rising white blood cell count. So if the white blood cell count was normal for a while and it starts to increase, or if the platelets start dropping out of the normal range and into a low range, those could be some signs that the polycythemia vera is maybe starting to behave more like myelofibrosis. So those would be some other things to keep an eye out for. But in general, the hematocrit is kind of the main lab value for PV that we are looking to keep tightly controlled.
Okay. And then, sorry, one last one rolled in, and I am
Sure.
going to cut it off here. But is SOB an indication of progression to accelerated phase or blast phase, given no increase in anemia?
Yeah, so SOB or shortness of breath is a what I call a very non-specific symptom. And what I mean by that is a lot of things can make you feel short of breath. I think it's very important for patients with MPNs. Sometimes and I'm as guilty of this as anyone, sometimes as an MPN specialist, I get blinders on. I just only think about, oh, it must be the MPN that's causing X, Y, and Z. But I think it's very important for symptoms like shortness of breath to be very broad and make sure, are there any things regarding my lungs, my heart, other things that should be evaluated perhaps by my primary care doctor or a different specialist before we say this is related to your MPN, and let's kind of investigate that further. So shortness of breath by itself, it's hard to say that this is an indicator of acceleration, but I think it's important to investigate why someone feels short of breath, and just as importantly, make sure that non-MPN reasons are being looked at as well.
Okay, wonderful. And thank you again, Dr. Patel. This presentation was so informative, and you did such a great job answering so many questions. So just thank you. It's always a pleasure working with you, and we appreciate everything that you do for the community.
Thank you so much, and thanks to everyone for taking the time to spend an hour with me. I really appreciate it, and I know that everyone has a lot going on, so much appreciated.
Excellent. And as we are wrapping up here, I did want to let everyone know that you can um, connect your personal health record and create a personal health record with the HealthTree Foundation. So this will have your labs, your treatment history, your vitals all in one place. So even if you're being seen at multiple sites and you're getting lab work from multiple sites, you can have all of that live in one easy to navigate place. And part of this, when we are talking about clinical trials, this will actually connect with clinicaltrials.gov, so we have all that information in here. but using your actual data, help you find trials that you may be interested in. So it's a very powerful tool that if you are interested in, I highly recommend checking out. And then we do have quite a few upcoming events. I just wanted to highlight three of them here. But on Monday, August 24th, we're going to have a community gather event. This one is actually for our caregiver community. So if you are or have a caregiver that could benefit from speaking with other caregivers, this is a fantastic opportunity to get them connected with others. These community gather events are not recorded out of respect of people's privacy. We really want to create a space where people can feel comfortable coming and sharing what they're experiencing. So if you are interested in that, highly recommend checking that one out. And then on Tuesday, August 25th, we have impact of GI microbiome on cancer progression. This is an exciting field of research that's, I feel like, gaining a lot of traction right now. So really good place to learn about how your gut microbiome can potentially impact cancer progression. And then finally on Thursday, August 27th, we are going to have one covering relationships, intimacy, and life after cancer. So again, another really good topic. So if you're interested in any of those, you can find them on the HealthTree website. I encourage you to register for any that you're interested in, especially the ones that have the recordings, because we'll send out those emails. And we'd love to see you there. And then finally, just want to thank you all again for coming today. Thank you to Dr. Patel for sharing your knowledge with us. This was a tremendous event. And then thank you to everyone for joining and listening. If you ever have questions or need someone to speak with, feel free to reach out to me. My email is just Dalton, Dalton, at healthtree.org. I love speaking with our community, so please reach out at any time. And then one quick reminder about that short survey that you can complete following the event. Give us some feedback about what you liked today, what you didn't like, and things that you'd want to see us cover in the future. But with all that said, I'm going to go ahead and close this out, and I hope everyone has a great day.
Thanks. Take care, everyone.